Okay, so we're on our third part. We've discussed the basic physiology of bone. We've discussed fracture healing. And now we're going to discuss failure in fracture healing. Now, the bone as a living tissue usually has a very good healing potential. There are times, however, or many times, other factors come into play and prevent a happy ending. Now, we're going to discuss some problems that may be implicated in or which may result in poor fracture healing. The first is delayed union. So when we say delayed union, it means that the bone did not heal or did not join together in the normal amount of time. So let's say if you have a tibia and you're expecting it to heal within 8 to 10 weeks and it has already been 15 or 20 weeks and yet you still could not see any fracture healing, there's still some motion, you could still see the fracture line, that could be delayed union. Your union is still, your fracture healing is still ongoing, but it's quite slow. It is slower than usual. On the other end of the spectrum is your malunion. Mal meaning wrong and union. Now in malunion, there is um, complete fracture healing. The fracture has healed, it has united, it is fixed, it's no longer moving, but the alignment is not optimal. This, for example, over here, this is a fracture of the shaft of the radius and ulna. You can see that there's obliteration of the fracture line. There's no more, you could no longer see the fracture line. You could see abundant callus here. And the problem is, number one, your radius and ulna has not healed in a straight line. It's bent. And what's even worse is that your radius and your ulna, their callus, became one big single callus. So your problem there is you have a loss of pronation and supination in your forearm, and that is very, very disabling. Now, when you have a fracture, whether a doctor sees it or not, whether a hilot touches it or not, chances are the bone will heal. The only problem is, the only question is, if it will heal in the proper manner. So that's why you put a cast or you put a plate or a pin to make sure that when the bone heals, it heals properly and not malunited. Okay? So the opposite of malunion is non-union. Just by looking at it, at the term, you see that there is no union. You wait after 6 months, there's still no union. After a year, after 2 years, there's no union. So you would say there is a failure of bone healing. There was never a union in the first place. Okay, so you see here there's two types, hypertrophic and atrophic. Um, Compare these two. These have fracture lines still, but here you can see callus formation. See? Bone is trying to heal, but it could not fully unite the bone. The main problem here usually in a hypertrophic non-union is that the bone itself still has the ability to heal, but because of, let's say, motion, it moves and moves and moves and moves, and it keeps on moving it did not unite. Now, remember, motion, that is microscopic motion, is good for bone healing. Very, very minute vibrations or motions are good for fracture healing. However, if the motions are big, if the motions are gross or larger than usual, then your tissues won't become bone. It would convert into fibrous tissue. And sometimes, if you would operate on this, you would see fibrous tissue here. It has formed another joint. So now you have an ankle joint here and another pseudo joint here. So this is hypertrophic non-union. The healing potential is there, but other factors come into play like motion. Excessive motion along the fracture line causes non-union. How about this? This one, you don't see any callus here. It's been 6 months na, there's no callus. So what's the problem? Is your bone healing a problem? Is your bone healing impaired? In this case, yes. You can see by the loss or by the absence of callus, bone did not try to heal itself in the first place. You would see atrophic non-unions in usually in areas like the distal tibia, where you can see only a small sleeve of muscle tissue surrounds the bone, and you could even find this in smokers, because smoking constricts the blood vessel and really screws up your wound healing. So in an atrophic non-union, the major problem here is your bone did not really have that healing potential in the first place, probably due to smoking, which is due to poor blood supply, or there's an infection, a slow burning infection there that prevents healing. Okay, there are many variables that you can count on when it comes to bone healing. These are things that you can check by looking at the history of your patient and by looking at how he was treated, and by considering them, you would be able to at least predict in a limited sense how good your chances are that the bone will heal. Okay, you have injury variables, how severe the injury is, where the injury was, patient variables, which includes, let's say, if the patient has diabetes, does the patient have any other comorbidities? Is he a smoker? Is he a poor follower or a very poor compliance to exercise regimens or treatment regimens? Tissue variables, the tissues there itself, and your treatment variables. What was done to the patient? Too much tinkering or too little tinkering or improper tinkering? Okay, so when it comes to injuries, let's say open fractures are severe injuries. Not only that you have a fracture, but you have a complicated soft tissue injury, which is open to the environment, and you have a high rate of infection. Infection will really screw up your healing process. Severity of an injury, um, very serious injuries would have periosteal layers or periosteum stripped off the bone. So if you have periosteal stripping, you're sure that that bone, that part of bone, would have a severe loss of blood supply, and healing is very, very poor. Here's another thing, intra-articular fractures, fractures within the joint. Why does it not heal well? If you would look at the joint, the bones there, the bone type is cancellous. Theoretically, cancellous bone usually heals faster than cortical bone. But the problem with intra-articular fractures is that inside your joint, you have your synovial fluid. The synovial fluid prevents hematoma formation. And can you recall the no? Can you recall the stages of fracture healing? First, you have your inflammatory repair and remodeling. In the inflammatory phase, very important gid ang hematoma formation. So if you cannot form a good hematoma, your fracture healing is off to a bad start. So that's why intra-articular fractures not very good, not very fast or a poor healing potential compared to other areas. Segmental fractures, we'll just discuss that next time when we deal with fracture configurations. Soft tissue interposition means that in between your fracture fragments, some muscle tissue or other tissues put themselves there in between. And of course, I think all of these would be attributed to your damaged blood supply or poor or impaired or compromised blood supply. Either you have periosteal stripping, damage to surrounding muscles that supply your bone, or damage to the nutrient arteries itself. Those are bad news. Okay, patient variables, age. The younger the patient, the better the healing potential. Pediatric patients have good healing potential. As you grow older, as you go in your senior years, your healing potential is also poorer. Nutrition. If you are well nourished, you have enough nutrition, enough nutrients to keep the energy of healing going on. Of course, you also have to think about obese patients. That's malnutrition in itself. There's too much calories and you have a very heavy patient, very big load for the bone. Okay. Lack of or hormones would include your diabetes, disorders in parathyroid hormones, okay, and always very 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 common, nicotine or cigarette smoking. Always ask the patient that with regards to when you're taking history. And not only will you ask him if he smokes or not, you ask him if he is living with someone who smokes. That's second-hand or third-hand smoking. Does he, in his workplace, do a lot of people smoke there? So that's third-hand smoking or second-hand smoking. Tissue variables, okay, bone type. What heals better? Cortical bone or cancellous bone? Bone necrosis, okay, going back to your bone type, cancellous bone heals faster than cortical bone. When you say bone necrosis, part of the bone dies. So in very severe injuries, you have the bones that have been hit and shattered on impact. Those are really out. I mean, their blood supply has been really stripped, and it's just going to die. Bone disease would include your vitamin D deficiency or rickets. You have um, osteogenesis imperfecta, those kinds of diseases. And very, very common infection. That is why open fractures are a concern. Infection, very whenever you see atrophic non-union or delayed union, always have it at the back of your mind. Is there a possibility of infection? Okay, tissue variables. Okay, let's talk about the last two, loading and micromotion. Micromotion, motion, a little bit of motion measured in micrometers, very, very minute motions in the fracture is actually good. Loading, meaning if you put a bit of stress on the bone, a little bit lang, is also good. It will help heal your bone. It will help with the bone healing. Of course, if you put excessive load and the motion becomes not just micromotion but macromotion, already measured in millimeters, the healing process will result not in bone formation but in fibrous tissue formation, and that would lead to a pseudo joint. Fracture stabilization. This is important because you need to stabilize the fracture. You do not want macromotion. You want micromotion. Now look at this example. This is an external fixator. Normally people would call this antenna. It's outside. This is outside your skin, and you see the pins coming in. These pins actually go straight to the bone. There. So, your fracture line is here, and what you're hoping for is this rod would be rigid enough to hold this fracture, more or less immobilize this fracture for around 6 to 8 weeks until your bone heals. If you have good fracture stabilization, if you have a very stable fracture stabilization, you can let the patient move. There's a little bit of micromotion, there's a little bit of loading, the other body parts are moving, so you prevent joint stiffness in other joint. In this case, you could allow the patient to move the wrist and the fingers and the elbow. So, more or less, you reduce the amount of disability that the patient has. Okay, how do you promote fracture healing? You have a good fixation and immobilization, stable, but not too extremely stable where there's no micromotion at all. That's not good. And you need to have, for example, if this is your fracture, you need the fracture ends to compress on each other. That's load. That's good. Bone graft is basically getting a piece of bone, whether from your own body or from a cadaver. You grind it. It's usually ground up, and then you put it in there. It's basically like putting new houses so that your osteoblast and your osteoclast will have something to stay in. So it's basically just for structure. Bone transport, you see this one, these ring fixators, this is for bone transport. Anyway, this is too complicated for now. We'll come back on that on our coming lectures, in the coming lectures. Okay, here's something as PT you would be more familiar with, or at least I hope you are familiar with. Electrical fields, meaning electrical stimulation. Can you still remember your electrotherapy? What is galvanic current? Is it AC current, meaning alternating current, or direct current? Correct. Galvanic currents are just another word for DC currents. So basically, you could put a DC current across or near the fracture line, and you are hoping that the electrical field will stimulate the fibroblasts, the osteoblasts, the other osteoprogenitor cells, and other proteins there to congregate on the fracture line or on the fracture area and improve healing. The same is true with ultrasound. Why? Why do you think ultrasound can help? Remember, we're talking about micromotion also. Some ultrasound is sound, and sound, when applied to matter, would also result, sound waves would create vibrations as well. Ultrasound or ultrasonic sound waves, you could not hear it, but it's very, very small vibrations, and that has also been proven to help. So, as PTs, you could actually help out in fracture healing, but not only in electrical stimulation or ultrasound. You also rehabilitate the patient well. Not only do you focus your efforts on the fractured area, like for example this leg, don't focus only on this leg, you focus on other parts. You focus on the other leg to make it stronger so that the patient could use it to walk on crutches, single limb. You focus on balance. You focus on skills like transfers, on using crutches, improving the strength of your upper extremities. Look at the patient as a whole. Do not look at the injury itself. Look at the patient as a whole. He has hopes, he has dreams, he has problems, he has fears, and he has needs, he has goals. Those are the things that you need to focus on. Okay, so this is the third and last part of our bone physiology series. I was hoping to do it in 10 minutes, but I doubled my time. Anyway, our next topic would be general principles of fracture fixation. So thank you for your attention. See you next time.